Hi everyone! Welcome back to the Step 1 review. Today we'll be doing high-yield psychiatry clinical presentations. If you need some additional practice questions, I have a $25 off discount code to the TrueLearn question bank. You can use the discount code SUCCESS25 and I'll have the link in the description box below. Let's get started. The first patient's going to be a child with bruising on the torso, long bone spiral fracture, and rib fractures in different stages of healing. This is going to be child abuse. The next patient's an elder patient with bruises in various stages of healing. This is elder abuse. Next, we have a baby with subdural hematoma and retinal hemorrhages. This is shaken baby syndrome, which is a form of child abuse. Next, we have a patient who's hyperactive or inattentive for at least 6 months, shouts out answers in school, careless with homework, and interrupts siblings at the dinner table. This is ADHD. Remember, you need to have either hyperactive or inattentive symptoms for at least 6 months in at least 2 different settings, for example, school and at home. Next, we have a patient with social deficits and repetitive restrictive interests and behaviors. So they might mention a child who plays alone in school and is obsessed with red trucks. This is autism spectrum disorder. Next, we have a patient under 18 years old who violates the law. They might be doing theft, destroying property, and fighting with others. This is conduct disorder. Next, we have a patient at least 18 years and above who violates the law, does theft, destroys property, and fights with others. This is antisocial personality disorder. Remember here, it's the age that differentiates between the two. Next, we have a patient with severe recurrent temper tantrums, and they'll be angry and irritable even between episodes, and the age is less than 10. This is disruptive mood dysregulation disorder. Next, we have a patient with recurrent verbal or physical outbursts, fail to control aggressive impulses. These episodes last under 30 minutes, and the age is above 6. This is intermittent explosive disorder. Now we have a patient with decreased cognitive and adaptive functioning. This is intellectual disability. Now we have a patient who's angry, irritable, vindictive, and defiant, and they argue with their parents and teachers. This is oppositional defiant disorder. Next, we have a patient who's a child who does not speak in certain situations. This is selective mutism. Often for this vignette, they'll mention a child who's really talkative at home, but the teachers say that the child doesn't speak at school. Next, we have a patient who's a child who has a fear of being separated from the parent or home, and they pretend to be sick to avoid school. This is separation anxiety disorder. Next, we have a patient who has a decreased ability to perform well in certain subjects. This is specific learning disorder. Next, we have a patient with sudden recurrent motor and vocal tics, like shrugging shoulders, blinking excessively, grunting, and clearing their throat. This is Tourette syndrome. Now we have a patient with a thiamine, which is a vitamin B1 deficiency, memory issues. The patient makes up information to fill in memory gaps, and the mammillary bodies are affected. This is Korsakoff syndrome, and this often affects people who drink a lot of alcohol. Next, we have a patient that has 2 or more distinct personalities. This is dissociative identity disorder. Now we have a patient who has altered mental status and they have an underlying infection. This is delirium. Now we have a patient with less than 1 month of hallucinations, delusions, and bizarre behavior. This is brief psychotic disorder. We like to compare that to the next two. So the next patient's going to have between 1 to 6 months of hallucinations, delusions, and bizarre behavior. This is schizophreniform disorder. Next, we have a patient with 6 months or more of hallucinations, delusions, bizarre behavior, and flat affect. This is schizophrenia. So the timeline here to differentiate these 3 conditions is very important. And for schizophrenia, oftentimes a vignette will describe a college-age student who doesn't shower and is occupied in their room hallucinating. Next, we have a patient with schizophrenia, but now also has mood symptoms. This is schizoaffective disorder. Now we have a patient that has delusions lasting over 1 month. This is delusional disorder. So remember, delusions are beliefs that are not true. Next, we have a patient with at least 3 of the following symptoms, including impulsivity, distractibility, increased self-esteem, racing thoughts, goal-directed activity, decreased sleep, and very talkative, pressured speech. These symptoms will be present for at least 1 week, and they lead to functional impairment. This is bipolar 1 disorder. We want to compare this to someone that has bipolar 1 symptoms that does not impair functioning and an episode of low mood. This is bipolar 2 disorder. Now we have a patient with at least 2 weeks of at least 5 out of 9 of the following symptoms, which include sleep issues, decreased interest, guilty, decreased energy, concentration issues, appetite and weight changes, psychomotor slowing, and suicidal ideation. This is major depressive disorder. Next, we have at least 2 years of mild depression symptoms that don't meet the criteria for major depressive disorder. This is persistent depressive disorder, also known as dysthymia. Next, we have a patient who's sad, tearful, fatigued, and they're less than 2 weeks from childbirth. This is postpartum blues. Next, we have a patient with recent childbirth, delusions, hallucinations, thoughts of harming the baby or themselves. This is postpartum psychosis. Next, we have a patient with recurrent episodes of palpitations, chest pain, sweating, fear of dying, and they're worried about having future attacks. This is panic disorder. Next, we have a patient who has fear in social situations such as public speaking. This is social anxiety disorder. Now we have a patient who's fearful in 2 or more specific situations such as open or closed spaces, lineups, crowds, and public transport. This is agoraphobia. Now we have a patient with at least 6 months of worry about different aspects of life such as work, school, children, and this is associated with feeling irritable, restless, having sleep issues, and muscle tension. This is generalized anxiety disorder. Now we have a patient with recurrent intrusive thoughts followed by repetitive actions. So this is going to be obsessive compulsive disorder. Obsessions can be things like cleanliness, and the compulsions that you use to overcome these obsessions are things like washing your hands multiple times. And this can be very, very time consuming for the patients. Next, we have a patient with hair loss with different lengths of their hair. This is trichotillomania. Next, we have a patient with less than 6 months of anxiety, stress, and worrying, and it's due to an identifiable stressor such as a divorce, illness, or moving. This is adjustment disorder. And remember, if it's 6 months and more, that turns into generalized anxiety disorder. Next, we have a patient with 1 month or more of hyperarousal, avoidance, nightmares, flashbacks, and a life-threatening event such as rape, a witnessed death, or injury. This is post-traumatic stress disorder. Now we'll go ahead and talk about the personality disorders. So the first one is going to be a patient who's very suspicious and doubtful. This is paranoid personality disorder. Next, the patient's going to be indifferent, enjoys being alone, and has limited emotional expression. This is schizoid personality disorder. Next, the patient's going to be weird, have odd beliefs, magical thinking. This is schizotypal. Next, we have a patient who's immoral, violates the rights of others, and is 18 years and older. This is antisocial personality disorder. Next, we have a patient with unstable mood and relationships, splitting, and you treat this with dialectical behavior therapy. This is borderline personality disorder. And remember, splitting is the mechanism of where you put people into like all good or all bad categories. Next, we have a patient who's flirty, dramatic, and attention seeking. This is histrionic personality disorder. Next, we have a patient with a big ego, entitled, and they lack empathy. This is narcissistic personality disorder. Next, we're going to have a patient who's fragile, sensitive to criticism, and fears that others won't like them. This is avoidant personality disorder. Next, we have a patient who's submissive. They have excessive need for support and low confidence. This is dependent personality disorder. Now we have a patient who's faking symptoms for an external gain and conscious motivation. So this is malingering. Oftentimes, they fake these symptoms to get rewards like money. Next, we have a patient who's faking their symptoms, has an unconscious motivation. Oftentimes, these patients want to assume the sick role and get attention. They'll have a history of multiple visits, procedures, and it's usually women in healthcare. So this is factitious disorder. And remember, it's important to have one provider following up with this patient to avoid multiple procedures and unnecessary testing. Next, we have a patient who's not faking their symptoms, unconscious motivation, and the symptoms are causing significant stress. This is somatic symptom disorder. Next, we have a patient with unexplained neurological symptoms after a stressor, and oftentimes these patients are indifferent towards the symptoms. This is conversion disorder. And remember, patients can have things like blindness, and it would be an alarming symptom to most, but in conversion disorder, they experience something called labile indifference, which is what I mentioned here about being indifferent towards the symptoms that sound pretty serious. Next, we have a patient who's worried about getting a disease but doesn't actually have any symptoms. This is illness anxiety disorder. So they're anxious about getting an illness. Next, we have a patient whose BMI is less than 18.5. They have a fear of weight gain. Either they restrict food intake or they eat, then vomit or use laxatives. It's also associated with amenorrhea, lanugo hair on the body, and osteoporosis. This is anorexia. Compare that to a patient with normal BMI over 18.5, binge eat and then compensate, parotid gland hypertrophy, and dorsal hand calluses from vomiting. This is bulimia. Next, we have a patient who binge eats without compensating. This is binge eating disorder. Next, we have a patient who eats non-food substances such as ice, dirt, and hair, and often this is seen in children and pregnancy. This is pica, and it's important to look for an underlying iron deficiency anemia in these patients. Now we have a patient with persistent distress about not identifying with gender assigned at birth. This is gender dysphoria. Next, we have a patient who's screaming in the middle of the night but doesn't remember the event, and this occurs in stage N3, which is non-REM sleep. It's the slow wave deep sleep stage. This is sleep terror. This is often compared to nightmares, in which we remember the nightmares we have and it happens in REM sleep. Next, we have a patient who suddenly falls asleep, has daytime fatigue, hallucinations just before going to sleep or just before waking up, and feels weak after laughing, crying. This is narcolepsy. Remember here, you have a decreased orexin production, and you can have these hypnagogic and hypnopompic hallucinations, as well as cataplexy, where you feel weak after strong emotion. Next, we have a patient who took recent medications such as SSRI, SNRI, TCAs, tramadol, and linezolid, and now develops hyperreflexia and a fever, and you treat it with cyproheptadine. This is serotonin syndrome. We compare this to a patient in the next vignette that has muscle rigidity and fever after antipsychotic use, and we treat this with dantrolene. This is neuroleptic malignant syndrome. Next, we have a patient who has decreased respiratory rate, increased temperature, and increased QT interval, and we treat this with sodium bicarb. This is a TCA toxicity. And remember, the sodium bicarb here helps stabilize the cardiac membrane. Next, we have a bipolar patient who gets nauseous, vomits, slurred speech, and dizziness, and they might have recent ACE inhibitor, thiazide, or NSAID use. This is lithium toxicity. Next, we have a schizophrenic patient who gets sudden muscle stiffness, and we treat this with benztropine or diphenhydramine. This is acute dystonia. Next, we have a patient who's hospitalized and gets hallucinations and tremors, and we treat this with a benzo. So this is delirium tremens, and this usually happens in when patients who previously drank alcohol are no longer getting alcohol and they can go into a withdrawal, and we call this delirium tremens. Now I want you to think about substance intoxication versus withdrawal. So we'll go ahead and mention some vignettes, take a second to pause, and try to guess what substance it is and whether it's a withdrawal or intoxication. So for the first patient, we have someone who presents with slurred speech and ataxia. So this is alcohol or benzo intoxication. Next, the patient's going to come in with tremors, seizures, hallucinations, and altered mental status. This is alcohol and benzo withdrawal. Next, we have a patient with decreased respiratory rate, pupil constriction, and constipation. This is opioid intoxication. Next, the patient's going to have sweating, yawning, a runny nose, pillar erection, stomach cramps, dilated pupils, and diarrhea. So this is opioid withdrawal. And remember, this often presents as a flu-like illness. Next, we have a patient that has a rash around the mouth and slurred speech. So this is inhalant intoxication. Next, we have a patient with dilated pupils. They're very alert and they might have skin excoriations. This is amphetamine intoxication. Next, we have a patient with pupil dilation, sweating, hallucinations, elevated heart rate and blood pressure, and chronic use of this substance can lead to a perforated nasal septum. This is cocaine intoxication. And remember, you can get the cocaine crawly, so you might even have tactile hallucinations in this one. Next, we have a patient who's restless, hungry, severely depressed, and has sleep issues. This is cocaine withdrawal, also called cocaine crash. Next, we have a patient who's complaining of a distorted reality. This is LSD use. Next, we have a patient with increased appetite and conjunctival injection. This is cannabis intoxication, and the red eyes are really unique to this one. Next, we have a patient who's irritable, has insomnia, and decreased appetite. This is cannabis withdrawal. Now we have a patient with hallucinations, increased thirst, bruxism, elevated heart rate, and blood pressure. This is MDMA use. Next, we have a patient with nystagmus and aggression. This is PCP use. Next, we have an alcoholic patient who presents with confusion, eye issues, and gait ataxia. This is Wernicke. Next, we have a patient who's an alcoholic, presents with irreversible memory loss, confabulations, and we treat this with B1, then dextrose. This is Korsakoff syndrome. So remember, Wernicke-Korsakoff happens due to a B1 thiamine deficiency. So you always want to replace the B1 first and then give dextrose. That brings us to the end of the video. Thank you so much for listening. If you have any questions, like always, feel free to reach out. And I really hope you enjoyed this video. And good luck studying, everyone. We'll see you in the next one.